So, good evening. So, we are continuing our emergency medicine series. Today's topic of discussion will be ABG. So, ABG stands for arterial blood gas analysis. So, in short, it can be told in other terms as acid, base, and gases. So, an actual ABG has two components. It deals with or it interprets the acid-base status as well as the gases. The gases, as you know, are oxygen and carbon dioxide. The acid base is about acidosis, alkalosis, etc., which we'll discuss shortly. So, before going, what are the indications for ABG? So, when all should be doing an ABG? Practically speaking, any ICU patient who is sick must be done an ABG because it gives so much of clinical insight. But the specific indications are any patient with breathing difficulty. Why? Because we should know about their oxygen and carbon dioxide status. Second indication, any case of poisoning. Because in some poisons, the bicarbonate will fall or some poisoning will lead to acidosis. It has implications in management. Third, any ventilated patient. In fact, for ventilated patients, it is advised to repeat ABG at least daily. And for some cases, after a ventilatory setting, every 4 hours it is warranted. Because we have to monitor or keep a particular target for carbon dioxide and oxygen. Post CPR, post cardiopulmonary resuscitation, it is expected that patients go for acidosis, so it's necessary for correction. And all diarrhea patients, because diarrhea is known to cause metabolic acidosis. So, in that case also we have to see ABG. There's a particular disease called renal tubular acidosis. In evaluating renal tubular acidosis, ABG is needed. Because this is a place where most of us will like to learn more and miss more. So, as I already told you, interpreting ABG can be classified into two parts. One, the acid-base status, like whether it is acidosis or alkalosis, and the second part is about gases. We are going to deal with oxygen and carbon dioxide. So, in today's part, we will be dealing with acid-base analysis alone. We won't deal much about oxygen. Carbon dioxide will come in acid-base also, but we won't deal much about oxygen today. So, we can go in a stepwise approach of how to interpret ABG. Because before going that, you should know about the normal values to interpret ABG. So, what is the normal pH of blood? The normal pH of blood is 7.35 to 7.45. On an average, it is taken as 7.4. Rather than telling the average value, you should know the range also. What is the normal bicarb level? It is between 22 to 26 milliequivalents per liter. On an average, it is 24. Then what is the normal CO2 level? Again, it is between 35 to 45 millimeters of mercury. On an average, it is 40 millimeters of mercury. Okay. So, pH is 7.35 to 7.45. Bicarb is 22 to 26. CO2 is 35 to 45. Remember that bicarb is a base or an alkali. Whereas CO2, it will become carbonic acid. So, CO2 is the acid here. And remember, bicarbonate is mainly dealt with the kidney because bicarb is one of the buffer. You would have learnt buffers in your physiology. Protein is a buffer, bicarb is a buffer, phosphate is a buffer. So, bicarb is a very important buffer, but this bicarb is absorbed or excreted by the kidney. So, bicarb is dealt entirely by the kidney, whereas CO2 is dealt by the respiratory system. You should know this because whenever a problem comes from bicarb, it is called as metabolic, like metabolic acidosis or metabolic alkalosis. When problem is related to carbon dioxide, we label it as a respiratory acidosis or respiratory alkalosis. So we have two issues when bicarb problems are there, that is metabolic acidosis or metabolic alkalosis. So as I already told you, bicarb is a base. So when base reduces, it will lead to acidosis, right? So to say metabolic acidosis, the problem should be from bicarb side and the bicarbonate should be low. Similarly, when do you say it is metabolic alkalosis? Bicarb has to be high. Then it is called as metabolic alkalosis. Similar with carbon dioxide. Carbon dioxide is an acid. So when carbon dioxide increases, we call it as respiratory acidosis. When carbon dioxide decreases, we call it respiratory alkalosis. Okay, so to deal about acid bases, we should deal with only these three values. Normal pH is 7.35 to 7.45. Normal bicarb is 22 to 26. Normal CO2 is 35 to 45. When the bicarb increases or decreases, we call it as metabolic alkalosis or metabolic acidosis. When CO2 increases or decreases, we call it respiratory acidosis or respiratory alkalosis. So now we'll go to the stepwise approach. So this is just a very simplified approach. Step 1. So whenever an ABG is given to you in an ICU, first step is always see the pH. Always see the pH. So as I already told you, the normal pH is between 7.35 to 7.45. So remember, whenever pH reduces, we call it as acidosis. When pH increases, we call it as alkalosis. So there are only two possibilities when it is abnormal. Either pH can be less than 7.35 or pH can be more than 7.45. So as I already discussed, when pH is low, we call it as acidosis. When pH is high, it is called as alkalosis. Okay. So when pH is less than 7.35, it is acidosis. When pH is more than 7.45, it is alkalosis. Very, very simple. Now go to the second step. So once it is acidosis or alkalosis, once we have labeled it as acidosis or alkalosis, our next step is to find out where is the primary pathology. Whether the primary pathology is with increase or decrease in bicarbonate or an increase or decrease of carbon dioxide. That is, whether the primary problem is a metabolic problem or the primary problem is a respiratory problem. So we will deal with an example. When pH is less than 7.35, that is acidosis. When it is an acidosis, automatically there comes two possibilities. Either bicarbonate, which is a base, this has to be reduced, or carbon dioxide, which is an acid, has to be increased. Right? Whenever there is an acidosis, the base bicarb should be low or carbon dioxide should be high. So as already discussed, when bicarb is low, we label it as metabolic, and this is an acidosis, so metabolic acidosis. So when pH is less than 7.35, we have to see whether bicarb is low or CO2 is high. When there is acidosis with low bicarb, it is metabolic acidosis. Similarly, when there is an acidosis with high CO2, we give the prefix respiratory acidosis. Similarly, we will deal with alkalosis. When pH is more than 7.45, we label it as alkalosis. For alkalosis to occur, either the base bicarb should be high or the acid CO2 should be low. So when there is an alkalosis with high bicarb, we label it as metabolic alkalosis. And when there is an alkalosis due to low CO2, we call it as respiratory alkalosis. So this is the second step. Again, a very simple step. So step 1 is to see pH, to label it as acidosis or alkalosis. Step 2, when it is acidosis or alkalosis, find out which component is problematic, whether bicarb is low or high or CO2 is low or high. Likewise, you have to label as metabolic acidosis or respiratory acidosis or metabolic alkalosis or respiratory alkalosis. So the most common, the third step is there's something called as compensation. So we'll start with the metabolic acidosis itself. So from our discussion till now, I told you for metabolic acidosis, pH has to be less than 7.35 and bicarb has to be low. Means bicarb has to be less than 22 milliequivalents per liter. What is meant by compensation is when bicarb comes down, our body will try to compensate and maintain the pH by correcting the other system. So when the metabolic side bicarb becomes low, from the respiratory side, the body will try to compensate. So how does it compensate? By expelling more acid. Since the bicarb is low, it is causing acidosis. So either you have to increase the base or reduce the acid. We can reduce the acid by expelling carbon dioxide. So CO2 also should fall. So how much does it fall? There is a formula for that. That is called Winter's formula. Remember this formula because metabolic acidosis is the most common metabolic abnormality. So at least you should remember. When there is metabolic acidosis, the expected CO2 should be 1.5 into bicarbonate plus 8. Okay, 1.5 into bicarbonate plus 8. We'll just give a value. For example, if the pH for a particular person, there is acidosis, bicarb is 18. So the expected CO2 for that patient will be 1.5 into 18 will be 27 plus 8, which is around 35. So PCO2, the expected PCO2 should be 35 plus or minus 2. Okay, this was just an example. So the expected CO2 in acidosis will be 1.5 into bicarbonate plus 8, the whole value plus or minus 2. Similarly, there are formulas for everything. If you are getting confused very much, don't think about the mechanism, just think about one rule, the same direction rule. Compensation always occurs in one direction. Like in metabolic acidosis, bicarb gets low, so to compensate, CO2 gets low. Same direction. If you think of the mechanism, you can easily understand it, but for easy analysis sake, I am telling like this. Similarly, we will discuss for metabolic alkalosis. In metabolic alkalosis, pH is more than 7.45, bicarb is more than 26. So compensation should come from the respiratory side. So CO2 should change. So remember the same direction rule. CO2 should increase because bicarb is high. So CO2 should increase more than 45 to compensate. Right? This is the same direction rule. You can think of the mechanism. You can easily understand. Base is increasing, so acid will increase to compensate. So how much will be the expected CO2 in metabolic alkalosis? We have another formula, 0.7 into bicarbonate, this whole value plus or minus 2. Like if you think this formula is too complicated, just think bicarb plus 10. That will be the average one. But this is the actual formula. Sorry, 0.7 into bicarb plus 21. The whole value plus or minus 2. Right? For Winter's formula, it is 1.5 into bicarb plus 8. Here it is 0.7 into bicarb plus 21. The whole value plus or minus 2. Okay, what about respiratory acidosis? In respiratory acidosis, pH is less than 7.35. CO2 is increasing more than 45. So compensation should come from the bicarbonate. By same direction rule, bicarb also should increase more than 26. So how much does it increase? Whenever you think of respiration, we have to tell two terms: chronic respiratory acidosis and acute respiratory acidosis. Acute respiratory acidosis is patient is normal, suddenly he gets a CVA, he goes for a respiratory compromise, he'll develop acidosis within hours. That is acute respiratory acidosis. Chronic respiratory acidosis, patient is having a chronic neuromuscular disease. So for days together, years together, they are having acidosis. So when things go acute, compensation will be less. So think of the formula in acute respiratory acidosis. For every 10 mmHg rise in CO2, the bicarb will increase by only 1, because there is no time to compensate. Whereas in chronic respiratory acidosis, for every 10 mmHg rise in CO2, the bicarb rises by 4. The 1 and 4, you just remember this. So what about respiratory alkalosis? Same thing. In respiratory alkalosis, pH is more than 7.45. CO2 will be less than 35. So to compensate, compensation comes from metabolic side, bicarbonate. Bicarb should also fall by the same direction. So what is the formula? Here also the same. Acute respiratory alkalosis and chronic respiratory alkalosis. For acute respiratory alkalosis, for every 10 millimeters of mercury fall in bicarb, the bicarb falls by 2. In metabolic acidosis, it is 1. In acute respiratory acidosis, it is bicarb changes by 1. In acute respiratory alkalosis, it is 2. So here, for every 10 mmHg fall in bicarbonate, bicarb falls by 5. In chronic respiratory acidosis, the rise is by 4. In chronic respiratory alkalosis, the fall is by 5. So this concept is compensation. So why you should know compensation is, so why knowing this compensation is important is, whenever things become chronic, like when there's a metabolic acidosis, automatically compensation occurs. So assume that we are having a metabolic acidosis, bicarb is in a particular range. We calculate the expected CO2, and the CO2 comes as per this formula. That it means it's a compensated disorder. So we are compensated metabolic acidosis, compensated metabolic alkalosis, or compensated respiratory acidosis or alkalosis. When things don't go as per this formula, it means either it is uncompensated, or the better term to say uncompensated is we are having a mixed disorder. Again, I'll just tell by a small example. Assume, just an assumption, the bicarb for a particular patient is 13. So it is a metabolic acidosis. So what's the expected PCO2 by this formula? Is 1.5 into bicarb level plus 8. So this comes around 19 or 20, around 28. 28 plus or minus 2. So expected PCO2 should be around 22. But we expect that the patient's PCO2 here is 40. Contrary to our expectation, the patient's PCO2 is 40. That is, it is higher than expected. So when PCO2 is high, what does it mean? There is a respiratory acidosis, right? So patient is already having a respiratory metabolic acidosis. Patient is already having a metabolic acidosis. The expected PCO2 should be 30, but the PCO2 in this case is higher than expected, which means it is uncompensated. Or in better terms, patient is having an added respiratory acidosis because PCO2 is high. So to find out mixed disorders, this formula is useful. That's why knowing compensation is important. So step 1 is very easy. See the pH, whether it is acidosis or alkalosis. Step 2, if it is acidosis, whether it is metabolic acidosis or respiratory acidosis. If it is alkalosis, whether it is metabolic or respiratory alkalosis. Step 3, find out the compensation, calculate the expected compensation. If things go as per formula, it's a compensated disorder. If things don't go as per formula, it is an uncompensated or a mixed disorder. Next step is step 4. This is exclusive only for metabolic acidosis. As I already told you, metabolic acidosis is the most common acid-base abnormality. Metabolic acidosis is of 2 types. High anion gap metabolic acidosis, normal anion gap or non-anion gap metabolic acidosis. So what is anion gap? Again, we are not dealing with actual physiology. It is given by the formula sodium minus your chloride and bicarbonate. Sodium is a cation, chloride and bicarb are anions. Anion gap is the excess of anions. That is the actual definition. We are not going to discuss it here. If anion gap, normal anion gap is 8 to 12 as per this formula. Normal anion gap is 8 to 12 as per this formula. If anion gap is more than 12, it is high anion gap metabolic acidosis. If anion gap is 8 to 12, it is normal anion gap metabolic acidosis. Why differentiating these two is important means when anion gap is high, it means some products are added to cause acidosis. So you can remember by the mnemonic mud piles. A very old mnemonic. The M stands for methanol, U for uremia, D for diabetic ketoacidosis, DKA, P for propylene glycol, S for I for iron, L for lactic acidosis, E for ethanol, S for salicylate. I usually tell a more simpler version. There are only 4 causes of high anion gap metabolic acidosis. One is DKA, diabetic ketoacidosis. So whenever a patient is having a metabolic acidosis with high anion gap, C for sugars. Next is uremia, that is CKD. CKD patients will have uremic acidosis. Next is lactic acidosis. Patients with sepsis, septic shock will have lactic acidosis. Fourth one, the general one, is poisoning, as we have already discussed. So the poisons are methanol poisoning, ethanol poisoning, salicylate, lactic acidosis, iron, propylene glycol, because all these are anions. When taken, they increase the anion gap. So regarding non-anion gap metabolic acidosis, normal anion gap metabolic acidosis where anion gap is 8 to 12. Again we have a mnemonic here. Mnemonic is hard up. I'll tell the simpler version first. Only 2 causes cause normal anion gap metabolic acidosis. Diarrhea or GI loss of any kind. Remember, GI loss of any kind. Another one is renal tubular acidosis. Like even in the mnemonic, we say it is hyperalimentation. which is diarrhea, acetazolamide, renal tubular acidosis. Like acetazolamide is a drug which causes renal tubular acidosis. D for diarrhea. U is urethral diversion. Like ureter gets diverted to the sigmoid colon, so that is also like diarrhea only. And P is pancreatic fistula. Again, when pancreas fistulates, it will lead to diarrhea or increased GI secretion. So in short, high anion gap metabolic acidosis is diabetic ketoacidosis, uremia, lactic acidosis and poisoning. Whereas in normal anion gap metabolic acidosis, we have diarrhea and renal tubular acidosis. Now the last step. Last step is a bit complicated step. So step 5. Never stop from here. There is something called as delta gap. Delta gap is delta anion gap divided by delta in bicarbonate. That is, I already told you the normal anion gap is 12. So delta anion gap is the change in anion gap from 12, and delta bicarb, then bicarb is the difference in bicarb from 22. We'll just deal with an example here. For example, patient's anion gap is 16. So what is the delta anion gap? It is 4. Okay, suppose the patient's bicarbonate is 28. The delta bicarb is 6. This is how the things go. Interpretation, just remember the normal value is between 1 to 2. That is, when bicarb is low, when bicarb is falling and correspondingly the anion gap is falling, that is the difference in anion gap, when it corresponds to the difference in bicarb, it means it is a pure high anion gap metabolic acidosis. If it is less than 1, when does delta gap become less than 1? When the bicarb difference is more, but the anion gap difference is not so much, right? 7. The delta gap is less than 1. What does it mean? When the ratio is less than 1, the denominator is high than the numerator, which means the change in bicarbonate is more than the change in bicarbonate is more than the change in anion gap, which means we are having an extra acidosis. So patient is having a high anion gap metabolic acidosis. Also, there is a normal anion gap metabolic acidosis. Now assume the opposite. When the delta gap is more than 2, what does it mean? The numerator is more, denominator is less, right? So the change in anion gap is more, but the bicarb change is not so much, which means there is something which is correcting the change in anion gap. Here it means patient is having a high anion gap metabolic acidosis plus a metabolic alkalosis. So this is something tricky to remember, but when you start analyzing more ABGs, this will become easy. So before going to an example, we'll just recap once for all. So this is a 5-step approach in interpreting ABG. Step 1, see pH. So the pH is less than 7.35, it is acidosis. More than 7.45, it is alkalosis. Step 2, if it is acidosis, there are two possibilities. Either bicarb is low or CO2 is high. If bicarb is low, we call it as metabolic acidosis. If CO2 is high, we call it as respiratory acidosis. Similarly, in alkalosis, there are two possibilities. Either bicarb is high or CO2 is low. If bicarb is high, we call it as metabolic alkalosis. If CO2 is low, we call it as respiratory alkalosis. So the third step, we have to calculate compensation. So in metabolic acidosis, the compensation is the expected bicarb has to be 1.5 into the actual patient bicarbonate plus 8. For metabolic alkalosis, the compensation formula is 0.7 into bicarbonate plus 21. For acute respiratory acidosis, for every 10 millimeters rise in CO2, the expected bicarb should rise by 1. For chronic respiratory acidosis, for every 10 millimeters rise in bicarbonate, rise in CO2, the bicarbonate should rise by 4. For acute respiratory alkalosis, for every 10 millimeters fall in CO2, the bicarbonate should fall by 2. And for chronic respiratory alkalosis, for every 10 millimeters fall in CO2, the bicarbonate should fall by 5. So if the values go as per formula, then it is called as compensated acid-base disorder. If it doesn't follow, it is called as a mixed acid-base disorder. So which all disorders are present, we have to calculate as per the existing case scenario. So the step 4 is, if it is a metabolic acidosis, we have to calculate the anion gap. So anion gap is given by the formula sodium minus chloride minus bicarbonate. Normal anion gap is 8 to 12. When anion gap is more than 12, it is called as high anion gap metabolic acidosis. When anion gap is between 8 to 12, it is called as normal anion gap metabolic acidosis. Causes of high anion gap metabolic acidosis: diabetic ketoacidosis, lactic acidosis, CKD, and any poisoning. If it is normal anion gap metabolic acidosis, only 2 causes: any GI loss, diarrhea, and renal tubular acidosis. And the last step is calculating the delta gap. Delta gap is delta anion gap by delta bicarbonate. So as I already told, if it is 1 to 2, it means the patient is having only high anion gap metabolic acidosis. Less than 1, if the ratio is less than 1, it means patient is having a high anion gap metabolic acidosis plus a normal anion gap metabolic acidosis. If the ratio is more than 2, patient is having a high anion gap metabolic acidosis plus a metabolic alkalosis. So I am repeating this again and again because I want everyone to be thorough about ABG interpretation. So we'll just finish with a small case example. Always, please remember, ABG should be interpreted in the light of the clinical context. For example, a person coming with high sugars, it's natural that we can expect acidosis. Like a patient with shock, okay, we expect lactic acidosis, so we expect a high anion gap metabolic acidosis. So always you have to interpret ABG based on the clinical scenario. So just a small example, we'll try to solve together. I'm not giving the clinical scenario. Patient has come with pH of 7.28, PCO2 is 24, bicarb is 11. We have the sodium chloride values also. So coming to step-by-step interpretation. Step 1, pH is 7.28, which is less than 7.35, which means this is an acidosis. So what is the step 2? If it is an acidosis, either it is metabolic acidosis or a respiratory acidosis. To say metabolic acidosis, bicarbonate should have been low. To say respiratory acidosis, CO2 should have been high. So in this case, either we expect a low bicarb or a high CO2. Which one comes handy? In this patient, PCO2 is 24, which is less than the normal reference range of 35 to 45. So this doesn't match. Bicarb is 11. That is, it is a low bicarb. So this comes handy. So patient is having a metabolic acidosis because bicarb is low. What is the third step? Calculating the compensation. So applying Winter's formula for metabolic acidosis, the expected PCO2 should be 1.5 into bicarbonate plus 8, the whole value plus or minus 2. So bicarb here is 11, So this comes around 24.5, right? We'll take it as 24 plus or minus 2. So this is the actual value. The PCO2 is coming in the range, right? So which means it is a compensated metabolic acidosis. This patient does not have any added disorder. It's a pure compensated metabolic acidosis. What is the fourth step? If it is metabolic acidosis, we have to calculate the anion gap. So anion gap is sodium minus of chloride plus bicarbonate. So sodium given in this case is 140. Chloride given in this case is 100. Bicarb is 11. So 140 minus 111, it is 29. It is definitely high because the normal anion gap is 8 to 12. So it is a high anion gap metabolic acidosis. So if it is high anion gap metabolic acidosis, what are the possibilities? Either it is a diabetic ketoacidosis, you have to see sugars. It is a uremic acidosis, we have to look for the creatinine value. Either it is a lactic acidosis, correlate to the clinical scenario, whether it is lactic acidosis, or it could be a poisoning. And what is the fifth step? Calculate the delta gap. Delta gap is delta anion gap by delta bicarbonate. The delta anion gap is, so normal anion gap is 12, the given anion gap is 29, so the difference is 17. Delta bicarbonate is, the patient's bicarbonate is 11, actual bicarbonate is 24, so the difference here is 13. So the 17 by 13 is around, that is between 1 to 2, right? So when delta gap is between 1 to 2, it is a pure high anion gap metabolic acidosis. So we'll continue about gaseous component in the next section.